Hi, everybody. My name is Matt. I'm a 11-year papillary thyroid cancer survivor from Seattle, and I am here to introduce our speakers for, I forgot the name of the session. It's okay. It, it's a Q&A with these guys. Start from the top. It's my pleasure to introduce Dr. Michael Tuttle. Dr. Tuttle is an endocrinologist at Memorial Sloan Kettering's Cancer Center in New York, New York. Dr. Tuttle is also a professor of medicine at the Joan and Sanford I. Wheel Medical College of Cornell University. He served on the American Thyroid Association committee that produced the current guidelines for the management of benign and malignant thyroid nodules. He also chaired the National Comprehensive Cancer Network Thyroid Cancer Panel and served on the Endocrinologic and Metabolic Drugs Advisory Committee of the U.S. Food and Drug Administration. Dr. Tuttle is a ThyCa medical advisor. Next, it's my pleasure to introduce Dr. Sarimar Agosto Salgado. Dr. Sarimar Agosto Salgado is an oncologic endocrinologist at Moffitt Cancer Center in Tampa, Florida. Her clinical interest centers on the management of thyroid nodules and all stages and types of thyroid cancer, including administration of systemic therapies for aggressive tumors. Her research interest focuses on intermediate high-risk thyroid cancers in terms of management, surveillance protocols, targeted therapies, and potential redifferentiation of tumors resistant to radioactive iodine. Last but not least, we have Dr. Jennifer Wang. Dr. Wang is an assistant professor in the Department of Head and Neck Surgery at MD Anderson Cancer Center in Houston, Texas. She is a surgeon scientist with a clinical practice focused on the treatment of patients with thyroid cancers. Dr. Wang also has a PhD in genetic epidemiology from the Johns Hopkins Bloomberg School of Public Health. She is a member of the FAST team at MD Anderson Cancer Center, facilitating anaplastic thyroid cancer specialized treatment team, dedicated to providing rapid diagnosis and treatment for patients with anaplastic thyroid cancer. And with that, just a little housekeeping. As I mentioned, we will run around with the microphone when you have questions in person. And did you want to handle the questions on Zoom, or would you like me to read them out to you? Okay. And I will read out the questions on Zoom. And we'll also have a raise your hand function if you want to talk your question on Zoom. And with that, I hand you over.
Perfect. So the good news is we have no slides. Yay. That's pretty good. We have no lecture. Our only disclaimer is we're probably going to make up half the answers, because I would rather go to any thyroid association meeting in the world of other doctors, because they don't ask us stuff we can't answer. You guys routinely ask us stuff we can't answer. So just get used to me saying, I don't know. Matt's got to run around. So we'll do questions. No, we don't do consults. Okay. So don't do 20 minutes. You can do a question, you can do a topic, and between one of the three of us, we'll probably have some idea. So who's first? Raise your hand. Who's first? First. There you go.
Hi, we're very glad you're here. So I've been super TSH suppressed for years. I'm like at 0.01. I can't sleep at night, etc. All the nice symptoms. However, my doctors still want me to stay that suppressed. I'm refractory, RAI resistant.
Refractory. Yep, I got you.
I'm on Lenvima and also on anastrozole for breast cancer, and just wondering if I'm too suppressed.
Oh, that's a great question.
I do have cardiac side effects as well.
Oh, I bet. Yeah. So I think this is a great question for Moffitt Cancer Center. Moffitt, Dr. Augusto, I'll teach you not to fly out here, young lady. So, Sarimar, you see these patients all the time with it. They're on TKIs and they're distant metastasis. Yeah. What do you do with the TSH, and has that changed over a few years?
Yeah, so first of all, I think this is a great question for two different learning points. I think for cases where we have a longer term favorable responses over time, that we see that excellent response with negative imaging and lower thyroid globulin levels. After certain years, we actually do de-escalate the level of the TSH suppression because of the risk of arrhythmias and osteoporosis. When we talk about RAI refractory thyroid cancer, we tend to try to maximize that TSH suppression. I personally, and again, obviously each case is individual, so I wouldn't say necessarily this would be direct medical advice for this case. But in general, when I have a patient on a multikinase inhibitor, these drugs by itself are associated a lot of times with side effects and weight loss. And if I have other comorbidities, where that could be affecting or symptoms, I sometimes tend to have necessarily a less suppressed TSH, still suppressed, but not as severe, just because I know lenvatinib by itself, or the drug itself, can cause weight loss. So I do tend to check periodically on the chemotherapy safety monitoring laboratories at TSH and 3T4, because I know that on a patient that used to be necessarily on a dose for the longest time, once they start systemic therapy, and even during systemic therapy, the requirements might change. So if they're starting to have pretty symptoms and they have other cardiac issues and they're already on systemic therapy, that's the setting where I personally see that TSH suppression can help, but it's not the main role. So I don't necessarily hesitate as much to decrease the level of the TSH suppression, especially if I feel that it can affect the tolerability of the treatments if it starts affecting quality of life.
I agree completely. This is something that's changed over the last 10 or 15 years. When I trained last century, I wish that was a joke. When I trained last century, everybody, we kept the TSH 0, suck it up. Everybody stayed there for 30 or 40 years. Now, most patients, we never have their TSH at 0. It's 1 or 0.5 or thereabouts. And I think you have to talk to docs and say, look, yeah, I know you want that number there, but if I can't sleep at night, my quality of life sucks. We're going to have to negotiate. And, you know, all of us want to do the best we can, but at some point you have to sort of say, yeah, I get it. That number's good, but I'm willing to accept that little bit of a risk because the benefits may be better than that little bit of a risk. So we try as best to make that balance. It's a little difficult for everybody, but agree. So it's worth pushing back and asking about. And for certainly anybody that's not with the distant metastasis, the days of having TSH forever are really gone. Yes.
On the same note, for people who have a suppressed TSH of 0.01, and it doesn't bother me at all, and I have low stable thyroid globulin in the setting of tall cell for many years, I'm reluctant to have them reduce that. And they're all saying, oh, well, you know, you're hitting 60 and you should start bringing it up to normal. I don't want to take the chance of finding out that it jumpstarts whatever residual cancer that I have. So what do you say to that?
I've been married 42 years, so I say yes, dear, a lot. It's that is a true story. Yeah, so I say baby steps. And so when somebody's been on it for a long time, you feel better because you're on too much, and let's just put it out there. And if I try to bring you down too fast, you don't like it, both psychologically and emotionally, everything else. So a lot of times I'll tell people, you've been on it for 15 years, let's take half a pill less for the next 6 months. We'll repeat your thyroid globulin. If it stays nice and low, no big deal. If you're the first one in 5 years, it goes up, then I'll raise the dose back up. So we do it kind of in baby steps. When I lower the dose, you guys generally talk me into another ultrasound, you talk me into another, right? It's just to have that reassurance. So I think as long as you're doing it in baby steps, it's reasonable. But if you actually come to my clinic, you'll find some people just like you and their TSH is still 0.0. And I've been telling them for 10 years, it needs to come down. And they go, I saw your video. It talks about risk versus benefit, and I'm willing to accept the risk. So I say, get off my videos. And so there are people that just will say, I will accept the risk of AFib. I'll accept the risk of that. Some people just feel miserable and can't. So I put that in my chart. And so we talked about it. So, but for most people, we can decrease these down gently. And if you're wrong, nothing gets dramatically out of control. The thyroglobulin changes a little bit or the ultrasound, but I hear you. I grew up on a farm and dad said, if it ain't broke, don't fix it. So I totally get that. So baby steps. All right, next question. Thanks, Matt. We're gonna get Matt to work out here today.
Hi, thank you for being here, both of you, all three of you, even on Zoom.
Yeah, thank you.
Yeah.
Yeah. Thank you.
So my question is, how does a person know, like, let's say a person is super suppressed, like 0.05 suppressed. How does a person know whether they have persistent disease or recurrence if, let's say, their thyroid globulin levels have remained the same? They're not zero, but they've remained the same. But then on the scans, they show like increased uptake in different areas.
Yeah, so sorry. Hello? So I think that's a great question, and it does kind of depend on your individual circumstance specifically, but in general, there are a number of different imaging modalities that we would do to investigate with our endocrinologist when there is a bump in your thyroid globulin. So that includes first looking in the neck, for example. So ultrasound, at least in our institution, will be kind of the first stop to look for something in the neck, and then kind of going from there.
Yeah, and sometimes you can't tell. When we made up the risk stratification a bunch of years ago, we talked about what's an excellent response and what's kind of an incomplete response. And then we made up this group called indeterminate. I originally called it acceptable. I thought that was a great term. Acceptable. It's acceptable. It's not an A, but it's a B. But when they wrote the guidelines, they said, well, that's a little judgmental. You can't say it's acceptable. And I said, well, I think it's acceptable. And they said, well, you're not personally writing the guidelines. So we use the term indeterminate. So sometimes it's indeterminate. Now, when something's been indeterminate long enough, you kind of go, probably not thyroid cancer, and make the steps. Yep. Okay. Next question.
I'm going to jump into Zoom questions. What can impact your thyroglobulin blood test increase outside of tumor returning? Stress, medications, cholesterol, or COVID vaccination?
Oh, that's fantastic. Good. I don't know. Sarimar, you want to do this one?
I think the most common thing that actually affects TSH fluctuation, thyroglobulin fluctuations is TSH fluctuations. So you always have to interpret ideally thyroglobulin in the context of a TSH. The more we liberalize a TSH, you can expect some fluctuation in the thyroglobulin. And the second thing is actually thyroglobulin levels. My experience can vary by assay. So ideally, you would like to, if you're going to be following long term, you try to follow on the same lab. I've had some patients that if they live at a certain distance, then I kind of have baselines on two different labs just to be able to make sure that we're comparing ideally during the same machine.
And to recognize that the thyroid globulin assay, it's not a single number. If it's 0.2, it's not going to be 0.2, 0.2, 0.2. I tell people, if I gave you a ruler and asked you to measure this wall behind me 3 times and measure it to the nearest 1,000th, you're going to give me 3 different numbers, right? That wall didn't change. It's a measurement thing. So most people are too excited about a TG that's 1 and then it's 1.5 or it's 1.2. So there's lots of subtle things that can do it. We don't see much of it anymore, but who loves biotin for their hair and knees and joints and all that kind of stuff? Biotin can sometimes mess up our blood test. Doesn't bother you, but it messes up the machines that we use. So if it's just a little bit of biotin in a multivitamin, no big deal. But if it's the bigger ones that you're using for hair and joints, you need to stop it for about 5 days before you have the TSH and the thyroid globulin numbers done. Yep.
For active surveillance patients, is there ever an off-ramp to yearly follow-up? If a patient has a stable situation year after year for 5 years or 10 years or more, can they stop getting checked every year?
So here's a true story. When we started the active surveillance program about 10 or 15 years ago, the Japanese have been doing it for 30 years. We're like the new kids on the block. And when I started telling people we were going to do this, there was a surgeon from Fox Chase called Drew Ridge. So Drew came up to me after a meeting and he said, I will support you starting an active surveillance program if you will promise me you will develop an inactive surveillance program. 15 years ago, he was way ahead of his time. So we're still trying to figure out the off-ramp right now. The real truth is none of us in the United States have done this long enough to feel comfortable that we know what's going to happen 10 or 15 years down the road. Now, that being said, once I've watched some small thyroid cancers with ultrasound for 5 years, the patients are coming back to see me every 2 or 3 years with an ultrasound. And after 10 years, I'm calling them and begging them to help my research. I know you're not worried about this. I'm not worried about this, but I need long-term data. So next time you're in New York, can you get me an ultrasound? So we are actively working on what that off-ramp is. I do have a good number of folks that are on the off-ramp in their 70s or 80s, because I work at a cancer center and they have other disease that they're not going to see life at 100. And so I've let a good number of folks off the off-ramp at that. I think it's a great question. I think we can absolutely do it. Part of it obviously is going to be the driver of the legal system in the United States and that sort of stuff, just putting it out there, right? So, but when everybody gets onto that, everybody's on board with it, I think it'll be fine. So we're not there yet. I don't think we'll be there for another 5 or 10 years. We need a lot more experience in the United States. The Japanese are ahead of us, and they've got most of the folks, if they haven't changed by 5 years, they don't change. Or if they change, it's not clinically significant. So it's something we're working on right now, but it's not going to be anytime soon.
Hi, could you speak about the potential negatives besides just not getting redifferentiated in redifferentiation? So what I mean is when the patient
Theoretically, yes.
Yeah, theoretically is unsuccessful, a month on trametinib. This is at Sloan, but a month on trametinib, and then trying for redifferentiation with an NRAS mutation, PDTC, and is unsuccessful. But after, like almost directly afterwards, like a lot of growth in the cancer. Was that directly related to thyrogen perhaps, or just that trametinib for this person did not work, so cancer had a party? I find that everybody gets super excited about redifferentiation, but I don't hear a lot of negatives, and people don't talk about what happens when it doesn't work.
That's a great question. Dr. Agosto, you live in this arena of redifferentiation. What are you thinking there?
Yeah, so I think negatives of redifferentiation, we could tackle this question from different aspects. So in full disclosure, I have done it outside clinical trials, and I usually have a good patient physician conversation, and at least we think of implementing this approach early on, but also not too early. And the reason is we still don't have necessarily longer term outcomes data on patients that have undergone redifferentiation. So at least on my personal practice, I implemented what I'm seeing a slow change that I feel this patient is going to need treatment, but that the growth is still not rapidly enough for me to determine that the patient is going to be on long-term care, long-term therapy. It's always a balance because you want to, the goal of redifferentiation is that you want to ideally buy some more time without having to be on long-term systemic therapy due to the changes in quality of life that it can have, the financial toxicity of being on chemo longer term. In the short term, during that period of redifferentiation, I quote my patients about a 40-50%, I would say, a risk of success based on the data that we have so far. The specific negatives in terms of risk of adverse events that can occur during that time period vary a lot depending on the systemic agent that it's being utilized. For example, specifically to trametinib, we can see some cardiac dysfunction. With BRAF/MEK inhibitors, there could be some rare side effects of retinal vein occlusion, thromboembolic events. And although these might not be common side effects, we still don't have a crystal ball to know who's going to develop a very serious adverse event to systemic therapy. And those side effects can occur during that short period of time that we're trying the chemotherapy. So that's something that could be seen as negative. Obviously, the risk of failure rate, you're giving more radioactive iodine. So by itself, you could be adding the side effects of radioactive iodine. Whether there is a course of that leading towards more aggressiveness later on? We think probably not, but again, that's where the need for more longer term outcomes data. At least based on the clinical scenario that it's being described, it sounds to me a little bit more of the biology of the poorly differentiated thyroid cancer actually taking on and manifesting what it sadly does in many cases, rather than from the redifferentiation process by itself would be my guess with the limited information that I have based on my experience.
Yeah, I would agree. This whole redifferentiation, redifferentiation is when the tumor doesn't grab on radioactive iodine. We put somebody on a pill for a month or 6 weeks and try to make it grab back on. And we call that redifferentiation, make it look more normal. We've been doing it for 10 or 11 years. And I think she's right. About half the time it doesn't work. When it doesn't work, we haven't seen any sudden growth or anything like that for the people that we've had on them in short term. Yeah. Yeah. So by and large, we haven't seen anything rapidly like that. Now you do have to get thyrogen, and the TSH does have to go up, and you occasionally see effusions and stuff with that. I mean, those kind of things can happen. So that's why this is not willy-nilly. I mean, I'm always the one saying, do something cool and do something new, right? And I've been pulling the reins back on this one. It's cool and it works in some good people, but we got to show that not only does it make the radioactive iodine scan positive, it makes people live longer and it makes people shrink stuff, and you can avoid more therapies. And we're still kind of early showing that sort of stuff now. So I think having that right space to use it in, and sort of being careful and use it appropriately. So sometimes you hear like everybody thinks this is like the coolest thing since sliced bread. And it is when it works, but it's also one of those that needs a little more information, a little more data, know exactly the right drug, the right people, because it's not without side effects when you take somebody through this. So it's real.
We do have a lot of questions on Zoom. We have 16 open questions. And Laura, I'm going to ask you to unmute yourself to ask your question.
Thank you very much. Can you hear me?
Yes.
Gotcha.
Okay, I hope you can't see me though. Please.
Okay, so that's it. Anytime somebody says that, then I go, "Oh, dude, we're looking right at you." So
Thanks a lot.
And then I feel bad. But go ahead, Laura. Ask your question to Moffitt. Go ahead.
So my question is that ever since my cancer diagnosis in July and my hemi surgery in September, I have tried to come to terms with this idea that things are never black and white in this world. And I'm always falling somewhere in between. I'm 51 years old. I'm falling in between. I'm a woman who's kind of menopausal, but not. I'm falling in between everything. My hemi was clean with clear margins, but I had isolated tumor cells in one lymph node. And I am really struggling with this idea that my quality of life is really going to go down the tubes if I do completion. So can you give some words of wisdom to me about this?
Yeah, well, it's nice to meet you, Laura. So I'm assuming the one lymph node was incidentally found around your thyroid. Is that
correct?
Okay. And, I to kind of broaden that picture out, we see a lot of patients in your situation where, there's no obvious disease in the lymph nodes when we do imaging to check. And during surgery, we do find lymph nodes that are, not clinically apparent, meaning that they're very small. So in our practice, we don't necessarily use that as a indication to go back in to do a completion thyroidectomy and to remove the lymph nodes that are in your neck. So I would say that it's worthwhile kind of speaking to different practices about your situation because you'll find that there is some variation in how we would manage that situation. And as you said in the beginning, it's not always black and white. So in this type of situations, it's worthwhile pursuing additional opinions.
Thank you. And so I guess the best thing that we can do is just find a doctor whose voice we think is the right way to go.
Yeah, pick your doctors carefully. The So the other thing I would say is that sometimes when we tell people that lobectomy is the right answer, we act like if we do a total thyroidectomy, we're going to totally destroy your life. Everything is going to go terrible. I can tell you in the vast majority of my patients, that's not the case. They're still moms, they're still dad. I've got Olympic athletes, professional ball players, and they're doing their life. So while I personally feel I'd much rather have these guys do a lobectomy, I think my patients do feel better if they have a thyroid left behind. Totally on board with that. If you need to have the whole thyroid out taken for thyroid cancer, the vast majority of people are going to do great. Those people live their life. They don't happen to be on Google writing every day telling you how terrible they feel. So not to minimize, I know there are 10% of my folks really don't feel good without their thyroid, but we can't freak everybody out that your life is going to go away if you don't have a thyroid. So I'd say in your case, from what we hear, I suspect you probably don't need it. And if doctors don't hurt you, you'll do fine for 105 years. But if you do need to have that taken out, the overwhelming odds are you'll do fine.
Thank you.
How do you determine if a person is resistant to the radioactive iodine treatment? Let's say they've had 2 with both same doses, or if they're just, or they were not given enough. Like, how do you determine if they are truly resistant or not?
Sarimar?
Yeah, so there's some defined criteria about refractory to radioactive iodine. Whenever there has been lesions that we're able to see them on a different scan, but they never concentrated iodine on any of the treatments, that would be one criteria. If you have a mixed population of some tumors that responded and some tumors that didn't, if you administer radioactive iodine and then you follow the patient and you see that the tumors are progressing between 6 to 12 months after the radioactive iodine, that could be also signs of radioactive iodine refractoriness, as well as if the lesions priorly concentrated radioactive iodine and now they don't concentrate radioactive iodine anymore. There's also some of us that also take into account at that point if we see, if we, for example, we do a PET scan and the tumors are very bright on a PET scan and have very high SUVs, which are basically units of measurement that tells me how bright that tumor is capturing the glucose metabolism from that we inject to be able to do a PET scan. Those tend to be tumors that do not respond to radioactive iodine. So for me to make that diagnosis, even though there are certain scenarios where you consider a diagnostic whole body scan to make the diagnosis, sometimes based on the criteria that I mentioned before, and based on the rate of growth that I'm seeing on the scans and the cumulative activity that has been given before, I'm able to actually render that diagnosis without having to do the diagnostic whole body scan.
Jump to a question in Zoom. Does having Hashimoto's cause false low thyroglobulin?
That's a great question. So so I'll come to that in a second. When we measure thyroglobulin, one of the things that messes us up is antibodies to the thyroglobulin, anti-thyroglobulin antibodies, right? The reason for that is the machines that we use to measure thyroglobulins, they use antibodies. The machine assumes you don't have any antibodies. If you got antibodies, guess what? You mess up our machine. Doesn't hurt you, but it messes up the way we measure it in the machine. So if you have those anti-thyroglobulin antibodies, there's the chance that it can make the number generally lower than what it really is, rarely higher. Sometimes it doesn't bother it at all. You just can't tell. If you have Hashimoto's thyroiditis or had it before we took the thyroid out, you're more likely to have those anti-thyroglobulin antibodies. So it's not really Hashimoto's thyroiditis. But when you have the Hashimoto's thyroiditis, they often have those antibodies against the thyroid. So that's why I never measure a thyroglobulin without the thyroglobulin antibodies. I don't care if the antibody's been negative for 10 years, doesn't matter. You got to do it with it every time whenever I'm doing the follow-up with that.
Hi, Dr. Tuttle and Dr. Wang. I'm just curious. I'm nearly 25 years out, papillary follicular variant papillary carcinoma, had a partial, had cancer 2.5 weeks later, had a completion, no cancer, had RAI, because back then everyone did. I've been suppressed all these years. I worked on getting out of the 0.0 something a couple years ago. I'm 0.5. I'm going to be seeing my endo like in a month or so. Should I be moving towards 1, 2? And my ultrasound, I have a beautiful clean, there's nothing there.
Yeah. So the real answer is we don't 100% know. We take it as a major win when we get somebody's TSH above 0.1, because we know at less than 0.1, if you're more than 50 or 60, AFib and funny heart rhythms, and if you're postmenopausal, soft bones, whole 9 yards. But you can still see all those changes at least up to 0.5, if not a little bit higher. So most of you guys, if you've done well, when I've moved you up to 0.5 for a year or two, I'll often decrease a little bit more. Now, this is new to most endocrinologists, and they are probably not going to be comfortable lowering down much more, even though you're ahead of them. But I have many folks in that situation. If we're 25 years down the road, holy cow, the TSHs are 1 or 1.5 or 2. So I think at 0.5, you're up into a safe range where you've really decreased the risk of anything bad. I also tell the endocrinologist, if the reason to keep the TSH low is so you can sleep at night, just explain it to the patient. It's not going to help you, but I'm going to really worry about you if it's not there. So I think at 0.5, you're in a safe range.
Yeah.
The other thing to think about is the TSH range is different as we get older. That 0.5 to 4.5 works great if you're 20 or 30. If you're old like me at 60 or 70 or 80, that normal range actually goes up to 6 or 7 or maybe even 8. So a 0.5 if you're 70 probably is a little more suppression than a 0.5 if you're 21, right? But all the studies have been done that way. So if I can get somebody to 0.5 and they will still keep seeing me, we'll take that as a win. And
So that's good. Because I've had fortunately no heart issues, osteopenia, but that probably would have come anyway.
I think that's in a reasonable area.
Thank you.
All right, who's next?
Can you talk a little bit about the effect of metformin on thyroid cancer, especially medullary thyroid cancer?
That's awesome. Okay, so the question, Sarimar, is metformin for thyroid cancer, and in specific metformin for medullary thyroid cancer. So instead of me just saying I don't know, and there's some data in mice and rats, from a real clinical perspective, how are you sort of thinking about that now?
I being completely and truthful, honest, I'm not aware of a current clinical trial or something for me to be able to comment if it's really significant or not on a day-to-day basis.
It's been circling around for 10 or 15 years. There's some compelling data in cell cultures and in mice that there maybe have some role in it. I don't think anybody's ever really studied it very directly. But it doesn't mean it doesn't work. It just means it hadn't studied directly. I do have some friends, though, that if you have medullary or bad thyroid cancer and you happen to have diabetes or need weight loss, they put you on metformin. They're kind of cutting this sort of in the middle. So right now, we just have to say we don't know. Yeah. Yeah, what she was saying was on metformin, the calcitonin went down, and when you stopped, it went up. It's been those kind of observation that keeps this around there. Now, it's a little hard, you get it fairly consistent because the calcitonin can bounce all over. But yeah, I've seen that once or twice as well, which is why I don't say it doesn't work. And what happened to you is exactly what we all do, is if somebody needed one of the diabetes medicines and you're in the cancer arena, we often go for metformin for that reason, not only for thyroid cancer. So, all right, middle of the back.
In terms of TSH suppression, what's a good range for a patient with PTC hobnail with RET fusion and many lymph node metastasis?
Yeah, okay, we're going to charge for this. So because the right answer is there's no one right answer. Maybe you're 25 years down the road and there's no disease at all. Maybe this is the first 3 months we're dealing with it. Maybe your thyroglobin's all over the board. So I use the TSH just as one tool. And yeah, I'll probably hedge my bet and keep the TSH a little less than 0.5 with that scenario as it gets started till we sort it out. But after you get a year or two down the road, I'm going to back off a little bit. I may back off a little bit slower than if you were a papillary microcarcinoma. So it's still very individualized. And keep in mind, we are totally making this up. What we've all agreed is that a TSH of 0 is not good for most people. We have not all agreed for an individual case, should it be 0.5 or 1. So that's why you'll get numbers all over the board. I suspect what I say on Friday is different than what I say on Wednesday for an average person that comes through. So just good to ask the question, mainly to help the doctors understand when it's time to get out of that heavy duty suppression at a reasonable time. In the back.
Hi, thanks for being here. I spent so many years super suppressed, actually TSH 0 for a long time. And I had a doctor, a very good endocrinologist who trained at Mayo, taught me something called the paradox of hyperthyroidism. And basically she explained that because I'm so overdosed, my body's running like super high. And because of that, I'm not sleeping well. Because of that, I'm not getting good rest. And it's literally making me hungry. And for those of you on Zoom, I am not skinny. So the suppression thing making you skinny didn't work. So I was wondering if you have any thoughts on that paradox of hyperthyroidism.
Yeah, so most of the people that I've talked into lowering their dose of thyroid hormone pills within a year tell me they feel better. And what they tell me is exactly what you said. They sleep better at night. When they're on too much, they fall asleep and they wake up too easy, which makes them tired the next morning. They don't get deep sleep. It drives the appetite, so it makes you more hungry. It feels like you've run a marathon 24 hours because the analogy I use is you feel good up to a certain point, and then when you go over the other side of the cliff, it's too much. And so getting folks back to the top of the mountain, and when I talk to people about lowering the dose after all these years, I actually leverage this. And they'll often go, yeah, I'm having those things. And then they usually go, why didn't you ask me about that 10 years ago? And I say, well, I didn't know about that 10 years ago. Welcome to 10 years now. And so folks will very often endorse exactly what you described there.
Thoughts on being near a large body of water when getting a CT or an MRI with contrast? How likely is it that radioactive material that ends up in the body of water? For that matter, what are the concerns of radioactive material from human waste, and how long does it take to break down?
Yeah, welcome to New York. So I get this question all the time. So a couple things. One, the contrast and stuff that comes with CTs and MRI is not radioactive. The contrast that comes with CT has normal iodine in it. We can actually see that, so we can see what's inside the blood vessels, so these guys can know what to operate and what to leave behind. And gadolinium is a different kind of dye. So no radioactive iodine from that. When you swallow radioactive iodine, you'll pee out the radioactive iodine about 90% the next 24 hours. Fortunately, it's such a small amount, it gets diluted out through the toilets. We flush it into the East River in New York, and I think it's probably good for the river. If you've ever seen the river, it's a good thing. So by and large, in that sort of scenario, we freak everybody out about it because it's really a relatively small dose of radiation. We freak you out at the hospital because of that relatively small dose we're given 8 or 9 times a week. And I've been doing this for 30 years. So little exposure to you guys over 30 years adds up to the professionals, right? You get it one time, not much of a worry for other those concerns. So by and large, it's diluted out. We've done studies around us because our patients have to stay in hotels because I work in Manhattan. And so the question came up 20 years ago, is it safe to be in a hotel? And should you tell the hotel staff? And what do you do with the sheets? We did tons of studies that show the amount of radiation is so low that it's not an issue whatsoever. So a good question, and you do want to minimize it to everybody else, but the reality is it gets diluted out so quickly, it's not much of an issue.
Do you have any thoughts on widely invasive follicular thyroid cancer?
You want to do this one, Sarimar?
Yeah, so widely invasive follicular thyroid cancer, meaning we see definitely more than four foci microscopically when we're looking at the tumors, when the pathologist is looking at the tumor under the microscope, it does tell us several things. Typically, if this patient had initially a partial thyroid surgery, this is usually a scenario where we consider doing the completion thyroidectomy. Follicular thyroid cancer typically is not as common in causing neck lymphadenopathy. And when I see kind of having my two hats on as an endocrinologist and as an oncologist, when I see patients with widely invasive FTC, I tend to have a lower threshold to look for distant mets in whether in the lungs or the bones. In that population of patients, when we I tend to have a lower threshold of evaluating even before radioactive iodine in case I already find some initial distant disease at presentation. It can alter my initial dose of radioactive iodine, but that's my practice and may be impacted a little bit by the referral bias that I receive patients that are coming in already with very high or concerning pathologies. And in addition, even if I see an excellent response after radioactive iodine, and I'm not seeing, meaning that there was the expected post-treatment whole body scan, and I'm not seeing any distant metastatic disease, it's definitely a patient that I follow much more closely than what I would follow a lower risk thyroid cancer. I hope that answers the question.
Another switch of gears, considering that recurrent laryngeal nerve damage does happen sometimes, the nerves are lost. Do you know of anything on the horizon, anything novel other than thyroplasties and injections that may be coming down the pipe in the next decade or so?
Yeah, I think there's certainly a lot of interest in that field, and people are working at various regenerative strategies. And I think hopefully in the next 10 years, maybe something will be more promising. But currently, at least from my knowledge, everything is in the preclinical state, and there isn't really anything that's going to come forth as being the go-to strategy yet. So I think keep your eyes peeled for something hopefully soon.
I was offered a reinnervation.
Yeah, well, I think that's that's another topic, but
Sure.
what we do know, if you're able to connect the nerves up at the time of surgery, you will at least get some tone, and that's certainly helpful. And
In the cases of classic papillary thyroid cancer, what methods are available to detect and treat early cases of distant metastasis beyond thyroglobulin monitoring?
That's a great question. So the crux of it is thyroglobulin. If you have antibodies who actually follow the antibody levels themselves, kind of as a surrogate marker. And then part of it just has to do with sort of the initial risk stratification. If you were low risk to begin with and there was no lymph node metastasis or 1 or 2 lymph node metastasis, the chance of distant metastasis is so low that if you go chasing with CT scans or PET scans, you're going to find what we call false positives, stuff that's not thyroid cancer. I grew up on a farm in Kentucky. You don't want to see my chest CT. It's got fungal infection everywhere, all over it. And if you did that, then you would have to prove that I don't have metastatic thyroid cancer. So you end up doing biopsies. So most of the time, we don't do anything outside of the neck ultrasound. And we've written papers now that said after you get a couple of those, you even need to stop doing those, because the only thing you're going to find on the ultrasound, you're more likely to find reactive lymph nodes and inflammatory lymph nodes and non-specific stuff that's not thyroid cancer. And you end up chasing and doing all extra studies and that sort of stuff. So by and large, if it's lowish risk, we don't need it. If it's higher risk, or like Sarimar was talking about the follicular variants and vascular invasion, there's everything from CT scans to MRIs to 18-FDG PET scans. So there's a lot of tools at our disposal that we can use. Occasionally, if you're really desperate, you can even use a physical exam. That worked really well for me for the first 10 years of my career before we had ultrasounds and all that other stuff. Still had 99% survival. So lots of tools that we can use, but fortunately, most of the time in classic papillary, you don't need to.
How often should a TSH suppressed postmenopausal woman have their bone density checked?
What do I know about bone density? So what, every couple years or something like that? So you're a real endocrinologist. Help me here. So when would you do the bone mineral density? I just do thyroid cancer. My wife says, unless you fall and hit your thyroid, I am no help whatsoever. Answer a bone mineral density question for me.
Yes. If we have a bone density and it's showing osteopenia, the first thing, I do is making sure there's no other causes besides age and the TSH suppression that are resulting in that. And there's if there is osteopenia, which you could see as a pre-osteoporosis, you can actually use something that's called a FRAX score to determine if there's need to treat or not. And I think the follow-up, depends a little bit on, if you need to treat or not. There's circumstances that because I practice in a cancer center, I've had patients that have also had other breast cancers and have been on treatments that can put them even more at risk of bone loss. So that's a setting where you could see probably a bone density in a year. But if you don't have any other causes, then you can kind of have the discussion with the patient. Can you then go back to then every 2 years? So a little bit of individualization there too, like with everything in thyroid cancer.
Okay, good. I wanted to know if you've ever seen on a lymphoma patient some fungal pneumonias, 2 or 3 in 6 months.
Another theoretical question. Sarimar, you do a lot more lymphoma than I do. Yeah.
So that's a very interesting question. In reality, although some of these oral antineoplastic agents, you take them at home and they might not necessarily lower your white counts. We still consider, or at least I still consider my patients to be more vulnerable to infections. I personally have not seen such a high frequency of pneumonias on lenvatinib. It's hard to tell if there's other predisposing factors, but if there isn't, then you have to consider that it could be related to them being on treatment. And so in that scenario, it's a scenario where we reevaluate, is there a dose reduction that's needed, obviously, and definitely in this type of scenario, I think this highlights the importance of working in a multidisciplinary team. That's a scenario where I, contact my pulmonologist and I said, do we need to work up this a little bit deeper and make sure that it's really, and also our infectious disease colleagues, because you want to make sure that the treatment then doesn't interfere with the systemic therapy treatment.
Is there any change in treatment for patients who have a comorbidity of autoimmune disorders?
I'm going to say no, not just because they carry a label of autoimmune disorders. Now, if you got autoimmune disorders that's bothered your kidney or bothered your heart or bothered your pancreas, because of that, that would have to be narrowed in. But other than that, I don't, from my standpoint, how I do the follow-up, they can have more positive antibodies, which makes my job a little bit harder. But other than that, not much. In the distant metastasis setting, Sarimar, how do you think about that?
So there are some histologies, like for example, in anaplastic thyroid cancer or more poorly differentiated rapid growing tumors, where there could be circumstances where a multidisciplinary team may consider using immunotherapy as part of the systemic agents. And that would be a scenario where considering if there's an autoimmune disease would impact potentially our choices of therapy and have us stay more on the targeted therapy realm.
That's a good thought. Yeah.
With regards to antibodies, is there anything that should be done differently? for somebody who has that comorbidity?
No, nothing different. Just if somebody has that autoimmune disease, I just know I gotta have to look for antibodies, and you do a little bit more follow-up. It's just harder to prove that somebody's 100% cured if they have the antibodies. So you end up following a little bit more closely, and the TSH stays a little bit lower for a little bit longer, and you do a few more ultrasounds. So other than just sort of how I do the maintenance and follow-up, the treatments and the outcomes, I don't think I'm trying to think it while you're asking me. I don't.
Well, are there any, because I
Yeah.
have one.
Yeah.
Are there any, like, from a drug perspective, like, do any of the drugs interact?
No,
because-
other than immunotherapy stuff, because immunotherapy stuff is turning your immune system on, and so, and it's not unique to thyroid cancer. That would be doesn't mean we couldn't do it, but it's like you take a second thought before you go down that pathway.
Okay, so the drugs that are given, like the immunosuppressors, are not problematic?
I'm going to bail out of this because you're asking me questions I don't want to answer. It's too specific.
Okay.
So catch me afterwards, and we'll talk about the individual ones. I don't want to give bad advice over Zoom here. Oh, it's okay. I know, Dana.
Can you share your thoughts on Hürthle cell cancer and recurrence rates?
So Hürthle cell cancer, you guys know they renamed this, right? So oncocytic, right? They changed the name. So Hürthle cell cancer has a bad reputation. It's not always a bad tumor. Occasionally you find small Hürthle cells that don't have vascular invasion, and surgery usually cures them. But when they're bigger, when there's vascular invasion, they're famous for not responding very well to radioactive iodine. So that kind of handicaps us. They're famous for being positive on the PET scan. They look to me a lot like follicular thyroid cancer in terms of how they behave and that sort of stuff. So just saying you have Hürthle cell cancer doesn't mean it's necessarily terrible. On the other hand, they can be kind of enriched in ones that don't behave as well. So it's one that you got to put it into context, the size and tumors and all the details. There's many, many different types of Hürthle cells. So it's one that everybody sort of freaks out about, but don't freak out till you talk to somebody that's seen a bunch of these to see if this is one that we're going to really, really worry about, or is this one that we cured with the surgery.
Do you have any information on stem cells for the treatment of salivary gland damage from RAI?
Yeah, so the answer is no. Other than people are trying all kinds of different things to help the salivary gland damage from RAI, because it is such a huge quality of life issue. I've been doing this for long enough. 20 years ago, I gave people way too much radioactive iodine. And now I'm watching it destroy their teeth 10 and 20 years down the road, like majorly with the dry mouth. So I'm living this, and we did it 20 years ago. So this whole idea of not using so much radioactive iodine, it's an important point. Folks are trying stem cells. Folks are trying viral injections into it to try to put the salivary glands back together again, make them work a little bit better. Thus far, everything is still kind of preclinical, but there are good folks working on this. Primarily, they're working on it because of the external beam radiation patients, the head and neck cancer patients that get that. They also get the dry mouth. So it's not just the few people that got radioactive iodine. From your guys' standpoint, anything other than that?
No, not exactly what you said. I know there are lots of people, at a high level academic institutions at NIH level who's working on this. So very excited about preclinical data, but again, we don't really know what the implications are at this point for clinical use.
How often do you see lymphedema occurrence after extensive neck dissections, and what can be done to treat or prevent lymphedema?
Yeah, that's a great question. So, when we talk about lymphedema after neck dissections, it does depend on how many and how much neck dissection was performed. We do see it from time to time. I think compared to other sites, such as for breast cancer, the rates of lymphedema after neck dissection compared to rates of lymphedema after breast surgery, lymph node dissection is lower generally, just because you have a lot more collateral flow in the neck. But certainly in neck surgery, we see it most often in people who've had extensive neck dissections done on both sides of their neck, so like a bilateral lateral neck dissection. And for that, when it does happen, there are actually lymphedema therapies that, for example, that involve manual therapies where they try to redirect a lymphatic flow that can be performed. And for example, we have a program at MD Anderson that can help with that situation.
I'm just curious. I'm from Canada, and my surgeon presented my case to a group of specialists. And because I specifically told the surgeon that I want to see an endocrinologist for all of this care after. And when they presented, they just said, no, your family doctor can deal with this. And every time I talk to my family doctor, who I work with, I'm teaching him about everything that he doesn't understand. So what can I do to have an endocrinologist want to see me?
That's a really good question. And I can actually comment on that because I train in Canada. So I probably have a bit more understanding of what you're talking about than most people in the room. So I would say that there can be ways around that. You will need to advocate for yourself because this is a different setting where resources are limited. Sure, there are many thyroid cancer patients who can be followed by the family doctor, but if you feel like you need to be followed by endocrinologist, I think that could be arranged. And there are certain endocrinologists at more associated with tertiary care places in Canada, sort of academic institutions that can take you on as a patient, and that requires kind of advocacy through your family doctor. And I'm happy to talk to you afterwards to maybe give you some suggestions.
The lymphedema made me think about so I've had a central and left neck dissection 9 years after my initial total thyroidectomy. If I ever needed the right, would that be a cause to go with an ablation or something instead of surgery to avoid the potential for lymphedema? I mean, I never thought about that.
Yeah, that's a good question. And I think there's kind of two aspects of this. One is that, yes, if you needed another comprehensive lateral neck dissection, your risk will be higher. But that being said, I think when we think about these alternative therapies to surgery for thyroid cancer, we have to be very careful about when to do that, because we don't know enough about these therapies in the setting of, in lieu of a lateral neck dissection. So surgery to remove all the lymph nodes comprehensively is still the gold standard. And for example, if you were to go in and just ablate one lymph node, but leave everything else in place, I don't know if that would make sense to kind of avoid the potential complications of lymphedema.
Can metastatic papillary thyroid cancer patients at intermediate risk of recurrence be reclassified as low risk when the postoperative thyroglobulin is low? After how long do we stop TSH suppression?
That's a great question. So when we invented the whole low, intermediate, and high, we had the option of saying you could start out intermediate, then you can change to low, and you can change to high. And we thought that would actually be confusing. So what we elected to do was leave low, intermediate, and high as the way you were born. It's your baby's weight, it's your baby's birth, it doesn't change. So it stays there because it reminds us where you started. And then on each visit after that, we apply another label to that. So you were intermediate risk, and now you've had an excellent response, or you're in remission. That's basically the same thing as being low risk. But to make it easier to teach, I left it as low, intermediate, and high, and then allowed us to say, okay, if you're intermediate and you do great, you're in remission after a year or two, then we say you have an excellent response. And 10 years later, if the thyroglobulin starts to go up, we remember you were intermediate way back then, but now you're incomplete or something like that. So what really happens is when you're low risk and do great the first year or two, or you're intermediate risk and do great, the risk of recurrence is the same at that 1 or 2 year point. It drops down to 1 or 2%. So you can sort of think about that as being reclassified as low risk. So yes, that's the idea. We want the doctors and we want you guys to think about it. I tell people it's like when I drove over here from the other hotel, I put it in the GPS system and it said, you're going to go this way. And after 5 minutes, it said, no, take this turn. No, take this turn, right? And so that's the way we sort of feel like walking through your history. We know where you started and we know where the plan was, but depending on what happens, maybe we become more aggressive or less aggressive. And more or less includes TSH goals. How often do you have to see me? How many ultrasounds do we do? All of that changes based on that ongoing risk, understanding that if I'm wrong, we'll change it again in a year or two and get it appropriately.
We got time for maybe 2 questions.
Hi, do you know if there is any correlation between 2 high doses of RAI, 10 years apart, and then 20 years later, the onset of invasive duct carcinoma in the breast?
That's a great question. The answer is maybe, just to be honest with you. We now have we've known for 20 years that when we give radioactive iodine, there's a very small risk of secondary cancers 20 or 30 years down the road, exceedingly small. I mean, I've been doing this for a long time, and I think I've had 10 or 15 of my patients over 25 years get what I thought was really a secondary cancer from the 2 or 3 doses of radioactive iodine. So does it exist? Yes. And one of the common things that pops up on that is sometimes breast cancer. Sometimes leukemias, lymphomas, salivary gland cancers, stomach cancers, exactly what you would expect, which is where the radioactive iodine goes. Now, on any individual patient, you never know, because if you had thyroid cancer, there's also the risk of having breast cancer with no radioactive iodine. So when we're dealing with these events that are so low, you just have to honestly say we can't tell on an individual patient. But if you've had a couple of doses radioactive iodine and you're 20 years down the road, if you got 500,000 people, you can find an extra 10 or 15 cases. So statistically, yes, but we don't recommend any screening for those other things because it's such an uncommon event. We just say do the normal mammograms when you're supposed to, do the normal pelvics, do the normal colonoscopies. But yeah, when I see somebody that's had 2 or 3 doses, particularly the larger stuff that we used to use, and then I see a leukemia or a salivary gland or breast cancer 20 or 30 years down the road, at least makes me think when I'm driving home, was I part of that? Maybe.
Last question. What could a patient do to maximize uptake in RAI?
You want to do this one, Sarimar? I've been talking too much. How do you maximize uptake so that they never see you? That's the goal. I mean, not in a nice way.
Yes, I think definitely making sure that it's appropriate for you to receive radioactive iodine. Make sure you have a good relationship with your doctor to have that discussion. Ideally, no CT scans with iodine, no CT scans with contrast within at least 8 weeks before having a radioactive iodine. If it is going to be by withdrawal, then our consensus is usually to ensure that the TSH levels are above 30, and then being compliant with the low iodine diet, which is a part of. I always tell my patients, we're going through taking this risk of doing radioactive iodine because we want to give you ideally good longer term outcomes in terms of lowering that risk of recurrence. We know the diet is not fun at all, but definitely considering the ThyCa cookbook in pre-planning and making sure that that you follow through, because it can make a difference.
This advertisement brought to you by ThyCa. Nicely done. That was good.
And with that, we're going to call an end to this session. Thank you for all the wonderful questions, and thank you for all the wonderful answers. We appreciate it. Thank you very much.
Good to see you, Sarimar. Thanks for joining.
Nice to see you, everybody, and thank you, everybody, for your kind questions.